Let's move on to the next case. In this case, a 28-year-old male who is a roofer by occupation, a roofer means a person who is repairing the roofs, presents to the OPD with complaints of breathlessness for the past 2 years. On examination, vitals were stable, clubbing was present. End inspiratory crackles were present over posterior lung fields, and there were signs of reduced air entry on right side. When we tried to listen to the breath sounds, we found that the breath sounds are less on the right side. Chest X-ray revealed bilateral streaky shadows and mild tracheal pull to right side. So this denotes actually mild fibrosis. So what is the most probable diagnosis? Well, you see, first of all, that there are indications in this case that it is a chronic disease. You see, the person is having complaints of breathlessness for the past 2 years, and there is a presence of clubbing. And clubbing is generally seen when there is a consistent hypoxia over a long duration. That hypoxia obviously is not severe. Okay, so in peripheral regions there is hypoxia. So this causes clubbing. So this is a chronic condition, and as seen in chest X-ray that there is presence of mild fibrosis. So we need to find out that why this fibrosis is present. Well, the clue lies in the occupation of the subject, which says that who is a roofer. Well, the construction of roofs require the presence of one material, that is asbestos, and the chronic exposure to asbestos can lead to this fibrotic lung disease known as interstitial lung disease. So this is a condition of asbestosis, which is basically a restrictive lung disease. So what are the other examples of restrictive lung disease? What are the features of a restrictive parenchymal dysfunction? What are the factors which affect lung compliance, and why are we talking about lung compliance here? And the next question is a note on the importance of pulmonary function tests. Yes, the diagnosis is asbestosis, and other restrictive lung diseases include the diseases which can directly affect the lung parenchyma, or the diseases which can affect the thoracic cage, because ultimately it is the expansion of the thoracic cage which is responsible for causing the expansion of the lungs. So any disease which affects the expansion of the lung parenchyma directly also causes restrictive lung disease, and affecting diseases which affect the thoracic cage also cause restrictive lung diseases. So let us see some examples. Well, you see, for lung parenchyma there is pulmonary fibrosis, radiation induced interstitial lung diseases. Then there is myasthenia gravis, because it will affect the contraction of the skeletal muscles which are responsible for expansion of the thoracic cage. Then kyphoscoliosis, which is basically the bending of the vertebral column, and vertebral column forms a part of the thoracic cage. So kyphoscoliosis will also cause restrictive lung disease, and excessive obesity, morbid obesity, will also affect the expansion of the lungs. So features of restrictive lung disease include decrease in total lung capacity, decrease in vital capacity, decrease in residual volume. Basically, you see, this is decreasing the expansion of the lungs, isn't it? Restrictive lung disease restricts the expansion of the lungs. So hence obviously these lung volumes and capacities are going to decrease. And what happens to this ratio, FEV1 by FVC percentage or ratio? It is normal, or sometimes it may be increased also. See, we are saying that vital capacity is decreasing, right? So usually there is proportionate decrease in FEV1 as well. So this causes this ratio to remain normal. Or if there is too much decrease in forced vital capacity, in that case this ratio may increase also. Then what are the factors actually which affect the lung compliance? It is important to know these factors because this restrictive lung disease actually causes decrease in the lung compliance. So if we are aware of these factors, we can predict that what can be the cause of restrictive lung disease. So anything which is affecting the lung distensibility and recoil will affect the lung compliance. For example, in this case, fibrosis or asbestosis, they are basically preventing the distensibility of the lung, decreasing the distensibility of the lung and thus causing restrictive lung disease. Then lung size. So at low lung volumes, when the lung size is lesser, the lung compliance is less, and at very high lung volumes, when we have reached our total lung capacity, in that time also lung compliance is very low. So lung size is also important, lung volume is important, surface tension within the alveoli is also important, because the surface tension is decreased by a substance known as a surfactant in the alveoli, right. So if this surfactant is not secreted, surface tension within the alveoli will increase, and this is going to increase the recoil of the recoil of the alveoli, and thus causing collapse of the lungs. Thus that is also going to cause restrictive lung disease. And finally, our last question was functions of pulmonary function test. So pulmonary function test is used for differentiating between the obstructive and restrictive lung diseases, that is diagnosing the respiratory dysfunction. Then once it is diagnosed, it is important for monitoring the progress of disease and what is the efficiency of treatment, the treatment which we are giving is working or not. So if we consecutively do pulmonary function test, we will be able to figure out any improvement in lung function. Then it is important for assessing the health status prior to recruitment, and it is also important for assessing respiratory fitness prior to anesthesia and surgery. So in summary, we discussed three important cases: a case of acute mountain sickness, a case of bronchial asthma, that is the obstructive lung disease, and a case of asbestosis, that is restrictive lung disease. Thank you.